Yeah, right here.
Good morning, everyone. Morning, and welcome to the University of Miami Miller School of Medicine. I am so delighted to be here with you. My name is Aziz Satius. I'm currently the interim chair for the Department of Informatics and Health Data Science, as well as founding director of the Media and Innovation Lab and part of the leadership of our sleep center, and as well as working with the Institute for Data Science and Computing. We're very excited. This is a monumental day. This is a bit of our coming out party as a department. And so I just wanted to thank everyone for being here, our esteemed guests, both internally as well as externally. We're very delighted to welcome you to the U. And as you can see, there's tremendous energy here at the University of Miami, as well as South Florida. So today, I want to share with you a little bit of kind of why is it that we've brought you here today. And in many ways, I think it's important to say a little bit about who I am and what we're doing. So one of my greatest heroes and sheroes is Helen Keller. And though Helen Keller had so many different types of physical challenges, limitations, and disabilities, that even though she could not see, she still had vision. Even though that she was unable to hear, she was still able to listen, to hear, to have empathy, and to build consensus. And so in many ways, this is what we're called here, because her story teaches us a lot. Here's what her story teaches us: that in the midst of challenges, that vision, collaboration, empathy, and community are critical in overcoming any challenge. This is a unique moment, and it requires going against the grain. And in some ways, it really calls us to suspend our natural impulses, our instincts, and our senses. And so what does that mean? It means, therefore, that we have to be able to listen with our eyes and see with our ears. You see, that really means going against the grain, and this is who I am as a leader. My life is the living embodiment of going against the grain. Growing up in Kingston, Jamaica, in an inner city community where I was in a neighborhood where it was perched betwixt and between a mountain and a valley. Where as a child, I would stand at my gate and look out, I would see the haves and the have-nots, betwixt and between. I was also betwixt and between because I was very much aware of the fact that there were the haves and the have-nots. And I think in many ways, we are in this moment that when I stood at my gate, what I believe I was doing as a child was that I was looking out at my destiny while looking behind at my history. This is where we are today. This is why I think this is an important moment. The University of Miami is betwixt and between. We are at this critical moment. We're between the historic town of Overtown and Brickell. And we are betwixt and between a broken healthcare system and dreams that we all have of making healthcare for all. So this is why this moment for me is very important. And so what I wanted to say and to show is that using the inspiration from Helen Keller, where you listen with your eyes and see with your ears, that I embarked on a listening tour when I came here about a year ago. And what I tried to do was to understand how is it that we can, in many ways, be a better figure. How is it that we can be a better messenger here in South Florida? And so I think there are some challenges that we face. And here is what I learned from the listening tour. What I learned from the listening tour were many confirmations and many consternations. Here is what we saw. There's some challenges that in our healthcare system, that there are some significant challenges, that there was significant need. There is expense, there is redundancy, and there is inequity. But what I learned from the listening tour, and we had over 70 different listening tours where we spoke to people like yourselves, that what I realized was that we are in a very impressive opportunity where we're at the cusp of change, where we want to be the beacon of hope. And so I also heard many different consternations. People asked, why the University of Miami? Why here? And why no? And it's important for us to share that we are faced with many different challenges, such as health disparities and chronic disease management. And when we're looking at these different challenges, that we believe that the department can help to solve some of our most vexing healthcare challenges and do so in a local way, globally as well as locally. We believe that in terms of health disparities, that there are significant disparities in outcomes and access, in terms of access to care, and that someone's race and ethnicity and socioeconomic status and geography are critical and impact whether or not if they get the right care at the right time. And we know how important social determinants of health are. And when we look at things locally, even in our own backyard here in Miami, that it is stated that about 21% of individuals here in South Florida are uninsured, which is double the amount here in the United States. But we also recognize that there are tremendous opportunities as well when it comes to health, technology, and innovation. That we believe that health, technology, and innovation are important. So while health, information, and technology has the potential to improve healthcare delivery and patient outcomes, that there are significant challenges related to data privacy, security, interoperability, and the digital divide and exclusion. This is where we are today. But in many ways, there are some significant opportunities for us, such as we believe that our department, through informatics and technology, that we can improve our decision making, that we can be the leaders in precision medicine, that we can be the leaders in improved patient engagement, and we can be the leaders in population health management. This is what we believe our new department will be able to offer. But as I'd mentioned, these were confirmations. We all knew this. But I also heard from the listening tour many consternations. People asked, why Why no? But let me share a little with you why and why no. Our university boasts as having over 19,000 plus students, that our research expenditures are high, that we have a very interdisciplinary ecosystem, and we are also ranked as #1 in NIH funding in the entire state of Florida. But also, I just want you to be aware of the fact that we here at the U, that we're no strangers to big visions as well as bold ideas. Why? Because it was the work of our informatics core that built the Oneness program with Jackson Health, stitching together different healthcare ecosystems that would allow us and to boast to have one of the most robust clinical data sets. It is also our Genomics Institute that said that we truly believe that all healthcare needs to be all for us. It needs to include all of us. It is also the fact that our environmental science department, who were very clairvoyant, looking and telling us way before ahead of the time that our earth was ailing. When we look at all these different atrocities, and they were linking how environmental health was actually related to our own health. It was our own Sylvester Cancer Center that boasts as the preeminent cancer institute in the entire state of Florida. And they were striving for the moon before there was a moonshot project. It was us, the HIV program here at the University of Miami, that in the 1980s, when people were shunning away from people with HIV, that they used reason and science and not fear to take care of individuals with HIV. It is the Institute for Data Science and Computing who said that we recognize that data is another equalizer and leveler, and it's the new currency that separated the haves and the have-nots. And we partnered with our local institutions, minority-serving institutions, to say, hey, don't look down, aim ahead. So this is what the University of Miami has always boasted. But it's not just us. There are wins ahead of us. There are wins in Miami, whereby there is such electricity here in Miami. We have representatives here from the government of the local municipality, and he can attest to the fact that just alone, that in Miami, there was $5.6 billion in venture funding last year, 34% increases in IT jobs. Our population is a growing one, but it's also a young one. We have several different tech accelerators, and 50% of the startup are first generation and immigrants. So we are here. This is our moment. And this is why it needs to be us here at UM, and it needs to be now. And the reason why that's important, and the way in which we want this new department to play the significant role, is that we here in Miami can now be the third coast for innovation and technology. That we don't need to look west for inspiration or look north for inspiration, but here in our own Miami and South Florida, we can be the leaders in this space. And so we want to create the third coast, or what I affectionately call Silicon Beach. This is how the department will operate. And so here is it now that we are not looking east or looking north for inspiration, but no, we are the ones who are inspiring these different coasts. And the reason why it's important is because we truly believe that innovation should be done for all. But what does this require? It requires that we think, act, dream, and lead differently, which requires a new mindset, a new appetite for learning, for practical application, and civic value. I truly believe, and I've always said this, that the mark of an innovator is not the innovator who is creative, but the one who anticipates what's next. This is how I will lead this department. It's about being where the puck is going to be. We want to be followers. We want to be leaders. We want to ensure that we position the University of Miami to anticipate what is next. We believe that our department is critical in this endeavor. Why? Because we see ourselves smacked right in the middle of this ecosystem between the University of Miami at large and Miami. It is critical for us to be this way. And I implore you all to join me in being part of this. Why? Because it's our technology that will serve as the engine to help us to decentralize, democratize healthcare. And in fact, it's already been shown that AI alone, artificial intelligence, is estimated to potentially save $360 billion per year for the US. We can do that, and we will do that. And so what we're saying is that our department has already started leading in this space. We have used AI and machine learning to responsibly deliver health equity. We have already started working with our partners to build smart cities as well as connected health devices. And we have started our very bold vision of creating remote health monitoring solutions where we can capture a variety of different clinical endpoints for patients so that we can measure them 360 degrees, and so we can create digital twins. We believe that the digital twin is the archetype that will help us to push us forward into precision medicine. Now, you may ask, what is then the mission of the department? We recognize that in order for us to achieve this, that our mission needs to recognize that technology is the engine for improved healthcare, where we can make healthcare more efficient and accessible, equitable, and thereby catalytic. Our vision is to identify and leverage and to scale innovations that demonstrate the greatest things, which is improving patient outcomes. And our values are steeped, whereby we want to see that we can emerge as credible thought leaders in medicine as well as population health. How are we going to do this? We are doing this in a way that we're going to be verticalizing how we operate. It's going to be a very different structure in our department. And the first vertical focus is on education. And sitting at the center and core of education is that we are going to make innovation the core. We've already started to create different innovation courses and different partnerships whereby our students can now boast that not only do they have a degree in the scientific method or a degree in engineering method, but also in the innovation method. This is the new phenotype of clinician and the new phenotype of scientist, a clinician innovator and a scientist innovator. We're going to do this in terms of research. And what we've already been doing is that we truly believe that our department will be known for our precision and personalized population health approach. What does that mean? It means, therefore, we're going to be leaders in how we collect data, how we process data, how we curate data, how we collate data, how we interpret data, how we analyze data, and how we disseminate data. Looking at data in a rhizomatic and multi-dimensional way. We're also going to be known for being the engine of digital biomarkers, because one of the things that we know is that we can accelerate discovery as well as clinical treatment by way of using digital solutions. And we believe that the future is ripe for this type of exploration. We also want to be leaders in decentralized trials. It's important to know that we do not want to leave any community behind. And what people oftentimes tell us is that their particular lifestyle does not fit in with the lifestyle of a research or scientist, and oftentimes they are excluded. So we're forging a decentralized trial initiative with some of our key stakeholders and partners, and we've already been leading in this effort as well, because we truly believe in order for us to make healthcare and science for all, that it must be democratized and it must be decentralized. But we're not just stopping there. We believe that we must also inform our clinical operations as well as dissemination and a new era, what we call electronic health, e-health. E-health is electronic health as well as emerging health. So we're going to be known for remote health monitoring solution. We've already created our signature, the mailbox, where we've sent it out to over 300 individuals throughout the entire South Florida and Northeast. We want to be leaders in decentralized care, what we call health at home. We want to be leaders in digital therapeutics, because what patients and people in the community tell us often, that they want alternative methods of treatment. We're going to be leaders in venture, that we recognize that oftentimes that, academic health systems oftentimes shun corporate enterprises and interests, and we are doing so responsibly, where we want to be leaders in spinning things out and spinning things in, that we want to be the engine of innovation here in South Florida and beyond. And we truly believe that we can do this in partnership with venture and the tech ecosystem. We have studied every burgeoning tech ecosystem, and they have a very strong academic partner. We at the U have to be that. We should not abdicate our responsibility, and we must do so. We're also going to be leading in the sense that we want to create a white glove industry engagement. So startups who want to do first in trial studies or want to do feasibility studies, that they will come to us and we will help to support them in that effort. We need to be that, and we will do that. Miami is calling us to be that person. And then lastly, we are going to inform how we provide service and outreach, and ensuring that in as much as we strive for the moon and strive for the stars, that we need to realize that we must rather ensure that we restore the covenant between ourselves and the community, that no one should be left behind. So we're creating initiatives around smart cities and smart homes, as well as providing upskilling for the workforce here in Miami, as well as trying to lead initiatives around social entrepreneurship. We are that beacon of hope, and we will have to be that. We want people in the community to know that they can see us as a refuge, that we want them to be better users and consumers of technology. And in order for them to do that, we must improve digital literacy, and we're working on those things. But here's what we're doing thus far, and here's our plan. This is our 3-year plan. We've done a university-wide listening tour, and we'll continue to do so. For those verticals, we're building these logic models, and we'd love your input in many ways as to how we can make it more strategic. We're going to be creating some very explicit deliverables for each of these verticals, and we ask you to help us with that. We're going to ensure that we create and recruit the best individuals, and we want to create an internal and external advisory board to keep us honest. Now, I know I've said a lot, but I just want to reiterate that this is Miami's moment. This is UM's moment to lead this tech and innovation ecosystem and momentum and anticipation. So this roundtable that we've assembled, and I thank you all for attending, brings us together with a singular purpose. We hope that this roundtable and many others to come will allow us to engage, to think differently, to recognize the value of the shared whole, to exchange perspectives with the desire to transform healthcare for all today. We're going to be doing this through education and research, and this represents the catalyst to dynamic change. We're going to do this through collaboration, whereby it will allow us to create scalable models and to see us really actualize our vision of being the third coast, or what I affectionately call Silicon Beach. And it will allow us to really foster and crystallize collaborations. But these collaborations begins with dialogue and open minds for success. And so we value your input. And so we'd love for you to snap a picture of the QR code, and we'd love to get your feedback as to how is it that we can better engage with you, the community. We want to hear from you internally as well as externally. And we will engage with you. So you will see all the fantastic team that we have. They're all donned in their fantastically, exquisitely gray t-shirts called the Media and Innovation Lab. So please reach out to them. They want to learn, and we want to learn from you. Now, despite this enthusiasm, do know that I'm very much aware that this will take a lot of work, take a lot of headaches, a lot of heartaches, and some kind of cynicism, whether it be grounded or ungrounded. But one of the things I will tell you, and I'm very resolute in this, that whenever we're faced with those challenges, whenever we're faced with challenges similar to what Helen Keller demonstrated, that all we need is vision and community. Because with those two, that we can do good through innovation. With that, I thank you. So at this time, I'd like to invite our fearless leader, Dr. Henry Ford. I'll tell you a little bit of story when he comes up. So when Dean Ford was recruiting me from up north, is it okay if I say the name of the school? From NYU School of Medicine. And I remember the day distinctly. It was Good Friday. It's a good day. It's a Good Friday. And, very comfortable at NYU. And Dean Ford shared a vision that I've never heard before. And he has been single-handedly responsible, as well as others here, in bringing me and the team here. And he embodied vision and community, and he embodies that. And we thank you so much. I thank you for the opportunity, Dean Ford. He has to jet out of here, so he's just kind of, coming in to say hi. So thank you so much, Dean Ford.
What a good move I made. Perhaps the best one. So after hearing a talk like that, where I come from, the first thing I would say is, can I get an amen? I mean, wasn't this amazing? I'm all psyched. I'm totally pumped. And you can see why Good Friday was so good to me that day, to be able to convince this extremely talented young man to come and join us at the middle school, because he's got incredible talent, just incomparable energy, vision, and I guarantee that he's going to elevate this institution into the pantheon of great research medical schools. And I can't even wait to see how far you take us. It's like what that great space explorer from Toy Story, Buzz Lightyear said, right? To infinity and beyond. Well, I will not try to mimic or imitate the eloquence of this young man or this passionate delivery of what you just heard, but it is exactly what we need right now. There's no question that the Department of Informatics, Health, Data Science is what we need to bridge the gap and ultimately achieve our collective goal of health equity, because that is part of the mission of the middle school, to make sure that all of God's children have access to excellent clinical care, regardless of their ability to pay, regardless of their ethnic, gender, or racial background. So I'm really excited about the work that's going to be done through this for this department, because all of the researchers, the basic scientists, the physician, the clinician scientists, and just about everyone, when they ask me, when I ask them what is it that we really need to enhance the research environment, the milieu at the Miller School, and that was back in the days when Dr. Schulman was the executive dean for research. The uniform statement, the consensus among all of them was, we need to invest in this department. We need to build this department, and we need to go out there and recruit a talented individual to lead it. Well, I'm here to say that I'm so glad that we have this leader, and we cannot wait to see what it delivers. So enjoy this day, enjoy the conference. I look forward to hearing about the proceedings, and I know that great things are in store for us, and especially for the citizens of South Florida and beyond, because after all, these are the people that we are responsible for. We're trying to improve their health. Thank you very much.
Thank you so much, Dean Ford. That's a very tough act to follow, so safe travels to you. Really appreciate it. And I think just Dean Ford's presence here and commitment, he has to literally jet. He's going to the airport right now, and he said he could not miss this, because this is really, our coming out party, so to speak. So again, thank you all so much, and thanks to Dean Ford. So I'm sure most of you came here to not listen to me. I kind of hijacked today's meeting, but I wanted to ground today's conversation. This month is Miami Tech Month. And I know some of the leadership is here, and they've done some amazing work. And so our group said, how is it that we could add value to this discourse that we've had for the past month here in South Florida? And we didn't have to think too hard. We recognized that the intersection of healthcare, technology, and equity is something that we need to discuss. But let me tell you a little bit about myself some more. That I truly believe that there are 4 different types of people in organizations. You have pointers, you have thinkers, you have doers and dreamers. And so today's conversation, I am very honored to have most of, I think, the most eminent people on this topic. And I'll tell you why. Because all 3 of them embody pointers, meaning identifying the issues. They are also thinkers. They think deeply about this issue every day, because I work with them daily. There are also dreamers, because when I speak with them, I always walk away energized knowing that if they're in charge, and we have some of the biggest hitting folks, one of the largest telehealth companies, one of the biggest tech companies, and one of the best cities in the country. So we have that representation here. And so with that, I would like to invite Dr. Patrick Carroll first. Just please have a seat. I'll say a little bit about them. They don't know I was going to do this. I was going to embarrass them a little. This was not part of our prep calls. So you don't mind if I call you Patrick, right? All right, cool. Exactly. So Patrick is a very dear friend of mine, and who serves as one of my mentors. We hail from the same college. We went different times, right? Slightly, a few years in between. College of the Holy Cross. And for those of you who don't know, our institution, the College of the Holy Cross, boasts some of the greatest public health leaders. Anthony Fauci and Pat Carroll. So Pat actually led Walgreens Health in that critical moment where everyone was going telehealth, connected care, and the like. He was a chief medical officer for Walgreens Health. And so he, in many ways, has been one of the chief architects in laying out how we practice telehealth and telemedicine, and how we have virtual care as well as connected care. So when I asked Patrick, I said, hey, we're doing this thing, and without a shadow of a doubt, Patrick said, I will be there. Why? Because we meet bi-weekly. every Monday. And it's him listening to me and just providing his wisdom. So Patrick, we're very delighted to have you here. Next, we have Dr. Marika Weber. So a little story between Marika and I would never comment on a woman's suit, but that's a power suit, Marika. That's amazing. So Marika is the head of research for the Northeast at Amazon Web Services. Embarrassing story. Marika reached out to me 2 weeks when I was about to leave NYU to come here. And I was like, I can't deal with another email. But something said, because we met previously and she was just so passionate about the work that we did, and we reached out. And since then, we've been working together for the last 2 years, and she, as well as her team from Amazon, have been working with us over the last 2 years to create this innovation infrastructure that I shared with you, and will continue to support us as well. So Marika, thank you so much for coming. And last but not least, Eric Gavin. So he's like just anxious now. He's like, what embarrassing story? So when I just landed here, Eric was one of the first folks from the mayor's office who reached out and said, hey, I hear the great things that you're doing. Let's meet up. And when people say let's meet up, you think it's just way in the future. And literally within a day, Eric and I met, and we've been chatting since, discussing how is it that the University of Miami, as well as the city of Miami, can interdigitate, interlock, to form forces so that we can force multiply. And so I know the mayor is a huge fan of the work that we're doing, primarily because of what Eric does in terms of voicing the work that we're doing. So Eric, we're just so happy to have you. And an alum, and he's also an alum of the U as well. So that's good. All right. So thanks again. So this is the fun part of today. I was so nervous around that, I don't know if you guys can see, but I really appreciate everyone being here and being with us. Okay, so Kayla is my lead, as you can know. So many of us talk about the intersection of healthcare and technology and equity. And we think here at the University of Miami, we can offer a unique insight on this. And so, we have a few questions, and I'll just kind of pass it along to you all. I think, one of the things that we'll start off with is, if you all could share in your own words, how do you see health TechQuity or tech equity? What does that mean to you? Anyone?
Okay. One thing I have to address that my friend Azizi said, I am not a huge fan of Silicon Beach. I kind of hate that term a little bit. And I'll tell you guys why really quick. Just simply, Miami is growing in such a completely different way than you would normally see tech ecosystems grow. And we'll dive into this during this panel, that if you try to do based on comparison, whether that's industry, whether that's side, like how we've been growing, the rate of growth, it doesn't necessarily add up in terms of a comparison. So, we're going to think of new phrases to think, and now we, talk about Miami, but Miami is definitely being a place that is compared because of how much activity and how much visibility is coming along. So just wanted to say that really quickly. But in terms of the question that you just asked, because Miami has been, over the last 2 years, health tech companies is the number 2 invested in terms of VC dollars across. And you saw a statistic earlier that stated about 5.8, depending on you asked, it's about, somewhere between 5.4 and 5.8 billion overall. Health tech companies are number 2 in terms of the percentage of that share of that 5.8 last year. And you're starting to get kind of questions come up in terms of, whether that's VC dollars or private equity dollars, what are the types of companies that are being invested in? And so down here for us, a lot of that is SaaS companies that are helping hospitals in some form or fashion provide better care. So for me in particular, what that really means is I love what you all are doing here at the U, because I want to see more things that help citizens, especially when you talk about distributed care, help citizens at a very ground level. Because those are the types of things, like I love seeing, private equity companies take, 10, 15 years working on certain types of pharmaceuticals. That's always going to be needed. That's always going to be necessary. But where the rubber meets the road, especially for my type of work, is how people receive that care and in what way they receive that care. So for me, that's a huge part of what I really appreciate.
Thanks, Eric. To me, the challenges in healthcare are around two issues, and this particularly is around equity, is access and cost. We have a terrible problem in this country with both. My background is I'm a primary care physician by training and practice, family physician with sub-certification in adolescent medicine. I practiced for 28 years in Concord, New Hampshire, and then I became a leader in a multi-specialty group, integrated delivery network, then 5 years at Walgreens, where I oversaw the retail clinics, which provided access to care. And what I do today at Hims and Hers is really about access through different modality, visits off a cell phone, right? That are both affordable and accessible. The biggest, the most important experience in my life, though, was going back when I finished my residency. I worked 4 years as a primary care physician on the Navajo reservation, and I went back 2009, 2011 to set up patient-centered medical homes and adolescent medicine clinics. And that really informed the rest of my career, because terrible access and equity issues with Native Americans, and we have pockets of that around the country. So for me, anything we can do to increase access and make it affordable is going to help solve the dilemma we have in this country around healthcare equity.
Yeah, I have to agree with both of those points, and I'll just add that tech moves so quickly, and it takes us as a community to catch up to that. And there's so many kind of fundamental values that are important to instill in technology that you can't do overnight. I mean, this doesn't happen overnight. And so I think it's really important for us to, like everything else that has been really earth-shattering, we have to understand it at a fundamental level. And that's hard to do when everything's moving so quickly and we're so busy and we're really just trying to make an impact. But we really need to slow down and understand the technology inside and out, make sure the community understands the technology, where there's weaknesses, where there's strengths, and communicate that. Like, let's make sure we all understand what that means and do our due diligence and make sure that we're connecting with like-minded individuals. That's really important. That human element is critical, because we can make everything accessible to patients and the community, but without that support and that sustained access to resource and community, it means absolutely nothing. And I think really the most important thing to do that is to partner and to look for like-minded individuals that have the same values, because without that, again, nothing matters, and that never changes. So I think this is a really good representation, and everyone here, that we all want the same end goal, and just by being grounded and, again, communicating, being very clear, is critical to making everything that we want to see equitable.
Thank you for that. So really appreciate that perspective, and let's roll up our sleeves a little, because I don't want this to be one of those armchair types of panels, right? We want to kind of dig a little deeper. So how can we actually achieve that? How can we, remove the digital divide, particularly as it relates to access? I think it's great that we talk about we need to be working with like-minded folks. Well, how do we do that? Because I think the audience here wants to hear at least solutions, or at least a strategy as to how we could potentially get there. What are your thoughts?
Many of you probably never heard of Hims and Hers. When I was a CMO of Walgreens, I got a cold call or email recruiting me there my 3 millennials said, "Dad, you got to go to San Francisco to interview." I said, "I never heard of this company." So I listened to them sometimes. So I flew out there. At the time I was at Walgreens, I reported to a 79-year-old CEO, nice guy, Stefano Piscini. I go out to hims and hers as a 30-year-old CEO, younger than my 3 kids. But what I saw he had a vision of is really access to care, particularly focused on millennials and younger. And they access care very differently than I do, or I did, which is, they don't go online to try to find a primary care physician with a major medical center. They Google up symptoms and look for answers. So it's really access to care is the focus of what we do at Hims and Hers. The reason why it works is that 24/7 access to care off a cell phone. Essentially, these are asynchronous visits. Our providers, there's over 700 around the country, can do the visit off the cell phone in an asynchronous manner, and our customers, our patients, do the same. So for $30, $35 a month, they not only get access to a provider board certified in every state, licensed in every state, but they also get medication sent to them. So for us, it solves the access issue using technology. As a primary care physician, it's tough for me to realize that that old model of a panel of 3,500 patients, 30 patients per day, please don't call me on weekends or after hours. It doesn't work anymore because there's not enough primary care physicians and nurse practitioners being trained. And quite honestly, for millennials and younger, that's not how they want to access care. They want to do it digitally. They want frictionless experience, and they want it affordable. So if you're paying $30, $35 per month, that's less than their $1,500 copay. And they don't even have to submit it to the insurance, because guess what? The insurance isn't going to cover them because it's below their yearly copay deductible.
And yeah, I mean, it's also assuming that, the audience that you're talking about or speaking to has a phone and has access to the internet and knows to Google search those types of things. So I think even taking a step further back, right, is educating the younger community that might not have internet access at home, and working with internet service providers to create programs that provide access to the internet, basically free of charge. So, I mean, that's one point. And then let's not forget about the elderly that also have a really difficult time with these new technologies and kind of understanding how to best utilize them. So I think, education at both ends of the spectrum, starting really young, providing places even within the community where underserved communities can come to get access to the internet and become more comfortable with technology, providing forums like this where leaders can get together and kind of brainstorm ideas on what types of programs to develop are really important. But supporting our younger generations and educating them. But even before that, making sure that they have access, like true access. And then what does support look like? Again, we just drop it in their hands, but how is the community going to hold their hand throughout this is really key. So we need people committed to that as well.
I love that point, because, one of the things that we've been doing in our department, so this past week, we've been posting on LinkedIn our Did You Know series. And one of the things that we found was that you're absolutely right. Part of the digital divide is people not having any devices at all. And when you stratify by income, that what we saw was that families that make actually $20,000 a year or less are less likely to have a digital solution. So Eric, I'm going to ask you, I know the city of Miami, you're doing a lot to help to bridge that digital divide. Do you mind just sharing kind of from the government standpoint, how are you trying to address some of those solutions? Because as Mariko mentioned, that you could do so through technology, and what Patrick said is that you could do so by making the system more efficient, but then you can't make a system more efficient or educate people if they don't have the basic resources. So can you say a little bit more about that, please?
Of course. One thing that to not be so airy about it is at the baseline, a lot of this is trust, right? So we're trying to establish relationships with people in the community so that they get to a level of trust to say, I'm willing to accept this service from you ultimately. So if you go into a community, and there's a bunch of communities that we operate in, whether you were talking about Little Haiti or Overtown or especially like Alapata. So like we go to those, I've been to those different places and I talk to community organizations and I ask the question, what services are they receiving now, right? What things are they comfortable with, coming to you and asking for to be able to continue something in their lives, right? And it's funny part about it is healthcare and technology are two of the things that they will completely avoid asking questions about, specifically because it requires information to be able to do that. So if you have to go out and ask somebody like, hey, I need this amount of information to help you to start with, it's going to cause a little bit of heartburn. And they're going to say, I'd rather not. I'd rather, take a step back and come to you another time, and they never come back, right? So establishing levels of trust to be able to say, there are community organizations that you work with every day, that food drive that you went to, we do that regularly where a lot of the commissioners will do food drives and say, hey, this time that you came to the food drive, would you be willing to get a checkup just to see if that would work out for you? And they say, yeah, sure, I would. Thank you for this food and thank you for giving this checkup, right? And it's these small things that you do to provide assistance within a community that starts to establish levels of trust to be able to say, now ISP provider, like, let's give you internet because you need internet so that you can actually even begin to start using some of the tools that we really want to do. A lot of the information and things that we gather in terms of data, we want to start doing more advanced stuff. But again, if they don't have phones or if they don't have internet, how are they going to be able to access those things on a regular basis? So you kind of have to start low tech to begin with and do this outreach, which seems very tedious. Like we have a lot of smart people in the room. And it's like automation. Like I do automation stuff every single day in the office. And that's something that we really pride ourselves on. But when you're talking about a lot of these communities that we're working within, communities that look a lot like myself, communities that I come from, you have to start with these basic, very rudimentary, let's go and have personal conversations with people and establish trust amongst these organizations and use the organizations as partnerships to be able to establish more higher levels of complex systems that you want to establish. So that's kind of our approach. We partner a lot with community organizations to be able to start leveraging up to more advanced systems or more complicated things that we want to do.
Yeah, I really like the points you're making because I was thinking earlier this morning, something I think that we're really missing is, I work with a lot of developers at AWS and they really love all of the technology, right? That's all they think about day in and day night. But, oftentimes them and a lot of the leaders that we partner with, I wonder about, have they ever heard from this community that we're talking about right now? 9 times out of 10, the answer is no. And so I think really getting on the ground and creating opportunities for that to happen is significant because if we have these people developing programs or technology or these leaders kind of paving the way, but they haven't really seen it through the eyes of the people that need it most, that's a huge miss. It's just not going to work. And we think about why certain movies and music and TED Talks are so moving. It's because the people that create those pieces of art have lived through that experience. So I think really pulling that through, and Azizi's in a really great position to do that and getting the voice of the community out into the hands of the people that can really make a difference is critical. So to your point, yeah, being on the ground with the folks who really need it most.
A little bit. Pat, would you like to chime in on?
Yeah, when I think of this whole topic, the area that comes top of mind to me is mental health. We have a major crisis in this country. I think it definitely was exacerbated by the pandemic. If you look at, the demographic, we serve everyone over age 18, but we have a focus on millennials and younger. 30 to 40% have anxiety, depression. There's a recent study out just among girls. Adolescent girls have an incidence of about 60% for anxiety and depression, and 20 to 30% have thought of self-harm in the past year. So we've got a major issue. If you actually look at access to care, with mental health. 60% of psychiatrists don't take insurance. So good luck finding one. Average of 50 days to access a prescriber, a psychiatrist, or psychiatric nurse practitioner. One of the more exciting healthcare verticals that we launched at Hims and Hers was around mental health. You can access a physician or a psychiatric nurse practitioner, psychiatrist or psychiatric nurse practitioner in less than 1 hour on our platform. 50 days, 1 hour. Top quality care, documented that the quality, because we use PHQ-9s and GAD-7s and regular follow-up and medications that get delivered. Top quality care that's accessible and affordable. And so the way we look at it is you have to approach healthcare in new and innovative ways. We will never solve the mental health crisis in this country if we go to the traditional model, because as good as it's been, it has really failed in terms of access and cost of care. And disproportionately, it really affects certain communities in this country.
Thank you for raising that. The reason why I like, what all three of you are saying is that it really makes the issue of TechQuity more nuanced, because oftentimes people are so fixated on whether or not you have access or not. But I love what you just mentioned, Pat. It's the quality, the nature of that, and the speed. Because what we do know is that, when we oftentimes design our technologies, I oftentimes think about my single mom who worked full time and went to school full time. And so if our delivery systems aren't, accessible in the way that it meets someone like my mom as an archetype, then we're not doing full justice. I'll stay with you, Pat, because what this really calls for are more disruptive modalities of care. And I know you're a big advocate of direct to consumer and the like. But how does one implement that? So for the clinicians in the room, or people who have clinics, what does that look like in terms of kind of establishing that direct to consumer approach? And how do you mitigate against equity issues?
Yeah, exactly. I can tell you that, my 25 years of practice, I did the traditional primary care, as I said, and one of my former partners reached out to me soon after I joined Hims and Hers through LinkedIn, and he said, "Pat, I can't believe you're working for that company. What's the most respected primary care physician in Concord, New Hampshire working for this healthcare startup doing digital health?" And he did say one more thing that's really ticked my wife off and bothered me as much. Says, "If you're that hard up for money, tell me how much you need. I'll send you a check." I thought, well, that's odd. That's a family physician back in Concord, New Hampshire, who's obviously not happy. But anyways, I think what you have to do as someone who's worked in the system is you have to realize that these new modalities are very threatening to traditional primary care, particularly. And I hear that all over the country when I speak in front of medical groups. Many buy into it. Physicians will approach me and say, "I don't get this. This is not good care. The quality's not there." And even state legislators, and we have a whole government relations team. You get pushback. How can you do asynchronous care? This is not really healthcare. Why are you calling patients consumers? Well, they are. And so I think what you have to do in order to make these really innovative models work, you have to focus on the quality first and foremost. That's table stakes for us. So I can prove through data and analytics that the quality of our visits and the quality of our encounters are as good, if not better, than most traditional brick and mortar practices. How do I know that? If you look at just mental health, every one of the customers who come on our platform, they get evaluated with a PHQ-9, a GAD-7, they get regular follow-up. We have full end-to-end visibility of whether they're in fact taking the medication, adherence to medication, and they get touch point follow-up content, digital outreach every 4 weeks. I never did that in my clinical practice. So if you lead with quality and you can prove that, it gives you license to do innovative approaches to healthcare. You just can't willy-nilly, though, set up, a platform. There was one recently, a company that did We'll prescribe Adderall over online, right? But there was no quality structure in place. They had 2,000 duplicate prescriptions for Adderall, so that clearly there was abuse going on the platform. You can't do healthcare like that. We made a conscious decision at our company. We're not doing controlled substances because the abuse potential is so high. So you have to lead with quality as you lead with innovation. The two go hand in hand.
And we and that'll take time. I think our regulatory bodies are playing catch up, and they need a lot of data and substantive studies that have kind of really put all of these potential technologies like through the ringer. So I'm kind of leading this support for a nonprofit agency, and they're funding a lot of researchers to look at a handful of modalities to provide that data back to the FDA. So I think in terms of partnerships, like these are going on. There's a lot of really great nonprofits out there that have a really wonderful mission that's supporting everything that we're talking about, and then partnering with AWS or other industry like-minded companies can get this work moving a little bit more quickly. And I mean, I'm skeptical a little bit about technology that's supposed to take the place of going in person to meet with my doctor. And so I think, and even coming from a medical background and now working in big tech, I mean, I think that says a lot, right? There's a lot of work that needs to be done, and so we have to standardize it. We have to help provide that data, and hopefully we're kind of doing that and headed in the right direction. But it'll take a little time, right?
Yeah, I love that. So I'll just kind of follow up with both of you, and Eric, feel free to chime in as well, because my follow-up question to you both, more so Pat, was you mentioned your family physician friend, Concord, New Hampshire, who was very skeptical, and I'm just curious, what do you think would change people's minds? And I think what Marika was saying is data, but I'll come back to you, Pat. What types of data do you think providers, payers want to see to convince them? And I'll probably chat with you, Eric, to see what do you think patients or the community wants to see to get that buy-in as well.
It's quite simply to set up a quality structure that cannot be questioned. And so last year at Hims and Hers, we did over 50,000 encounter reviews. So if you're a provider on our platform, you're going to get reviewed randomly. You're going to get reviewed if there's customer complaints. You're going to get reviewed if you're an outlier, if you're seeing patients too fast. We want to make sure that you're in fact covering everything that needs to be covered. Our providers get graded on 5 criteria. Website manner, do they introduce themselves? Do they establish a connection with the patient? Are they following clinical guidelines? Are they prescribing the appropriate medication at the appropriate dose? Is their note comprehensive and cogent enough that the next provider can actually pick up the chart and understand what went on? So I think it's really being able to show that we provide a quality structure that includes random, vigorous reviews. And guess what? If you don't score 90% or more on these reviews, you're asked to leave our platform. So we're willing to let providers go if they don't meet the standard. I've worked in primary care, but I also led, CMO health system for a 2,000 physician multi-specialty group for retail clinics. I can tell you the quality structure we set up exceeds anything that I had instituted in those really traditional healthcare ecosystems that I came from. So I think you have to go above and beyond in terms of proving the quality. You have to show it day in and day out, because we're still on trial where there's still a lot of skepticism out there.
I love that. So I don't know if Eric, you want to chime in?
No, literally the only thing I would chime in if we're talking about, regular customers is you follow your traditional innovation model where there's early people who are going to come in and try these new innovative ways. And then you have people who after are like, I'm not sure if I'm ready to try that. I'm not necessarily sure if this new innovation in healthcare is something that I want to dive into. But eventually, as these new innovations, like what you all are doing at Hims and Hers, begin to take root and everybody sees that this is like an objective way to do healthcare better, more and more people over time will continue to adapt to that. So, I mean, I hate being the person in tech that says like it's only a matter of time, but it kind of is. It's only a matter of time before some of these things become so commonplace and so efficient and so cost effective that they start to take root a lot more than they currently are.
I think that's a good point.
You know,
Go ahead, Pat.
Yeah, the one thing I'll add too is not everybody's appropriate for a virtual experience. And so 10% of our customers, we refer off our platform, and we refer them into specialists. We refer them to primary care physicians. We're not treating diabetes. We're not treating folks with unstable angina. We know our swim lanes and we stay within that. One of my big initiatives this year is to establish in every state a health system partner. And we hope it's UHealth in Miami, where the thousands of patients per day nationally that we refer off to our platform have a place to land with a great health system partner that can access their cardiologists, their dermatologists, their urologists to get that face-to-face, in-person care. Digital health, virtual health cannot manage every health issue, particularly as you get into more complex chronic conditions.
I love that point. And I think I love where the conversation is going, because as we're talking about data to standardize care, I think what I'm hearing echoed throughout your thoughts is the fact that we need to make it more tailored and more contextualized, particularly for groups of individuals from different communities. So my question to you is, what strategies can be employed to ensure that healthcare technology is designed with diversity and inclusivity in mind?
Yeah, I mean, I think the people at the table, like I mentioned before, doing the development and doing the work need to be diverse. And I mean that in every way possible. Different background, different studies, different everything. It's not, diversity just doesn't mean we have different color skin, right? It means that we've experienced a different life. It means we've been trained on different things. We see the world in a different way. It's really important to have like-minded values, but a different like perception and where we're coming from, because without that, we can't get where we need to go. And I know tech has been making a really big effort to increase and diversify their workforce, but like everything else, it's a process and it's going to take a little time. So we have to create job opportunities and just make the voice much more complex, really.
Pat?
So, I mean, I think you made a really, really good point in that respect. The one thing that I'm appreciating about this tech ecosystem in particular is that some of these aspects of diversity are kind of coming up naturally in the way that people are developing these companies because of how naturally diverse our ecosystem generally is. But that takes effort though, because you can't just kind of have a community that is diverse and then automatically your tech ecosystem or your professional workforce becomes diverse by nature. It's how you recruit people. It's how you bring people in. So I think as we kind of start to see this ecosystem in particular grow, you will start to see companies that take that into consideration because the client base is so diverse. They have a huge consideration about their team being diverse and who leads their company being diverse. So that, again, it's not just in skin color, it is in terms of diversity of thought in the way that we approach how care and service is given.
You know, the one thing that I think is critically important is with these companies, they need less people like me. They need more folks who come from a diverse background, who actually have different points of view. And I'm talking about from the board down to the C-suite on down. And at our company, we've made a really conscious effort to have a very diverse board representing lots of different backgrounds on the board of directors, right to our C-suite, from our CFO through our chief marketing officer, and then right down to our providers. We are really have doubled down in terms of getting a diverse group of providers. You know, we have a 97% retention rate of providers, so we can be very selective of who we have on our platform, because even in a digital environment, digital health environment, you don't want 800 physicians with my background. And you need some diversity to understand some of these issues, particularly as we look into the mental health space. So I think you need companies that have that cause clearly in mind, and they are going to go for diversity because that's what you need in healthcare. It just can't be monochrome.
So I love the fact that you all have been talking about the importance of data and ensuring that the data are representative. But how do you do that? What are some steps, particularly for you, Mariko, and you could talk for yourself or AWS, but what kind of steps can be taken to promote equity in like the collection of data, the analysis and interpretation? Because I think we all agree from today's conversation that we need to set up certain structures that will diversify and ensure that the products are diverse. Mm-hmm. But the data that goes into it may not actually be diverse. So what are some ways in which we could go about doing that?
Yeah, well, from early on to the conception of the idea and the development of the protocol, the standards need to be set up front. And perhaps that's difficult for some groups and companies because they don't know how to set those standards up and what diverse data actually looks like. So in order to do that, they have to go out and they have to recruit the people who've set up design protocols that take diversity into consideration, to use their expertise or just pull in other team members that may have this expertise. Because I think oftentimes, more than not, we're trying to move the needle away from a standard that's been used up until now, right? That's been consistent, and a lot of people don't understand what having diverse data means and having and being inclusivity, what that actually means. So it takes some personal adjustment, right? That's a commitment, like a true commitment from the individual and the team and the company. And it also means it might take a little bit longer than we're used to. And so that's kind of just a vague way of saying, understanding what change needs to be done and committing to making that change and not veering away from that. Like to me, it's that simple. Just do what you're going to say you're going to do and do it. But time is of the essence, and of course, we want to get things done quickly. And I think people oftentimes focus more on that than actually doing it the way that we need to. But I certainly think we're shifting away from that. So I think it's in the near term. I'm hopeful.
Well, I think we're all, inspired and excited to hear kind of how you and others lead in that space. But while we're on the topic with regards to data, so as you can see, we have a diverse audience here, and both in here as well as virtually. And people might say, you know what, Patrick, Mariko, Eric, I think you are great advocates and ambassadors for technology. But sitting at the center of that is, data. But they're not, sure that their data are actually confidential or private, particularly in healthcare and technology, especially, folks of vulnerable population. I think, Eric, you kind of mentioned that, it leads with trust. What are some initiatives that you're leading that could share with us as to how you're actually, ensuring that you're entrusting, bringing, trust in the process?
So it's not a secret that people don't trust government generally. So traditionally we have things that we can operate and do, and I'd start from a data perspective from the government is that anything that I do or create or collect can be FOIA'd. And for people that don't know, that means somebody can do a freedom of information request and say, hey, I want this information from you, Eric, and it could be data that we collected on an event we did or a program we did or something else. And that, for a lot of people, is a huge surprise because you end up doing something and it ends up being great and ends up being a service for someone. And now a breach of trust has occurred. So from our perspective, what we try to do for the most part is, what is the highest impact thing that we could do with the least amount of data about said person, which is problematic in a different way because data helps us personalize things. So a lot of the services and things that you're going to start seeing roll out, especially with how much AI has been so prevalent this year and the end of last year, is because we're able to take in huge amounts of data and personalize it based on people's responses and or how they've operated online in some form or fashion. That's going to continue to be a constant as we move forward. And what I hope doesn't happen too much is that people start to separate themselves with their online personalities and the data that they put online. You see it a lot in social media right now where people put anything out online and put a lot of information out and disassociate themselves from what they present online. And that creates issues kind of down the line to say, like, I didn't know I was giving out that much. I didn't know that people could do that much with my information. So as we move forward and we start to think about healthcare in particular, that's going to be an issue. People are going to put out information where I didn't know that this type of information could present in a healthcare concern or a healthcare decision making for a company that now affects me in some particular way. I always remember in one particular situation how Target was able to assume and guess correctly that somebody was pregnant before they even knew. And that was simply because of what they bought and how they bought and the frequency in which they bought. And so you're going to start seeing things like that happen a lot more often, where information that you provide, information that you present is going to be used in order to maybe not target you, but identify you much more easily than you originally thought. So that's going to be a thing as we move forward. And that's something that, it's a little scary for some people, but in other ways can be something that is used to definitely benefit and help people in a way that they did not know.
You know, I absolutely agree. I think the challenge in our space, particularly direct to consumer, is we do omni-channel approach in terms of marketing. So we do Facebook, we do TikTok, we do, you name it, YouTube's. And some companies have got into trouble because what they're doing, what they have done in the past, although they've been called out on it, is using their data, healthcare data, to market. And you know, you have to have that firewall between the two. Otherwise, it's a real slippery slope. Sure, it can enhance your marketing efforts, but you're not protecting the privacy and the healthcare data. You have to be really careful with that. And that came up recently in the last 6 months with several companies. And so as much as, you know, your marketing team may want to pull some of that in, we just don't allow it because you know, the anonymity, the patient's personal healthcare data is sacred. It's theirs, and unless they agree to share, it is their data.
So Marika, I have a special doozy question for you.
Yeah.
So I think what, you know, I love what Eric and Pat said about, you know, data. And I think oftentimes, you know, there is this push for openness and democracy of data. You know, as, you know, technologists, you know, we often say, make it open source. But the folks that we speak to, like patients, don't want their data to be open source. And there's this tension. How do you reconcile that, you think? And how is AWS, or, you know, is reconciling that tension between having data more open source to spur innovation, but yet people are saying, no, I don't want you to have my data. I'm not comfortable with this openness and democratization of data.
Yes, I come at it from a couple of different viewpoints. I mean, from a researcher's perspective, I'm like, yeah, having access to more data is great. We can replicate findings more easily. The more data you have, the better we can create our machine learning models. More is better in that respect. But we do work with a lot of academic institutions where there's a lot of patient data. And so this is at the forefront of the institution and AWS, I mean, security and protecting that data. So we build out secure research platforms and environments such that this data is protected. And federal agencies, have these requirements in place. We abide by those requirements. We make sure that all of the policies are in place before any research can be conducted, like on our platform. But when it comes to kind of giving patients choice behind whether or not they want their data available is really important, and explaining to them how the data is going to be processed, how it's de-identified is really important. Just making sure they understand exactly what happens before it becomes open source, and the good that it can be for kind of larger research studies, and saying you can say no, like that's okay. You don't have to make your data available even though it's de-identified. So being clear on the expectation, giving a choice, and also sharing the value, I think are three really key important things.
No, I think that was excellent put. The only thing I would add is open source right now, traditionally was open source the way that we, the programming, the code that we use, the way that we developed how we process something or how we were to build something, right? So a lot of these open source programs, you would go on and you would say, hey, somebody has built out this algorithm. I'm going to use it to then process this other set of data, right? And then now we have things that are moving beyond what census data was, which census data has always been open, and the government data has always been an open thing. But now there's a lot more open data sources that traditionally we did not have before, that starts to bring to question, at what point do we start to draw a line in terms of what type of data do we say this is okay and this is not okay? Is anything on the internet okay? Because technically right now, if anybody in this room puts something on the internet, I can guarantee you myself or somebody on my team could scrape it, like 100%, without much, hassle about it in any type of way. But for people who are using the internet every day, you may not know that. You may think that those things are protected in some form or fashion, but legally, they're not really that protected because there's been a lot of fights over those types of things. So at what point do we start to say it's getting a little bit too far along the line to say that this information, it should be protected in some way that traditional healthcare data is protected, or traditional patient data is protected in particular? That may be a concern that comes up in the future, but as it stands right now, that's an open dialogue that's continuing as AI becomes more prevalent and we're using it for more flexible things than we originally thought that they could be used for.
Thank you. I'd love to have a follow-up, but I've been given the cue that we have to wrap up soon. A gentle cue, so thanks for that. I'll just have two, final questions, almost rapid fire, but they are some of our biggest questions. So I think the audience is, I think they've been so patient in hearing about tangible solutions, and I think you all have offered some clarity around strategies and a way forward. But then there is some level of consternation, and I think I shared that in my opening kind of monologue, so to speak, was people may be worried or concerned, like, what is the cost to achieve equity? And I mean outside of the economics of it, but what are the resources? Because we have great ideas, and I think everyone here is mission aligned, value driven. But again, this is a kind of a margins driven industry. What do you think it will take to achieve health equity? What kind of resources are needed?
Let me start. Everything in the world. I'm just kidding. No. But I mean, so a lot of resources, a lot of time, a lot of planning and engagement and partnerships. And partnerships, I'm going to focus on that because, right, I mean, as you've seen, all the great work that Aziz has been able to do up until this point is because he's leaned in on partners. And these partners usually have a lot of money, and there are people within these organizations that want to do good work. And I think I'm going to go back to the first point I made, finding those people at those organizations and making those connections and proposing your program or your idea or the impact that you want to make on the community, proposing that early on and getting buy-in and getting that support is possible. I mean, anything, truly anything is possible. And so it may not always come in the form of cash, but there are, other ways like resources and, at AWS, there are credits where you can do work in the cloud free of charge. There are ways to supplement getting the work done. And I would just heavily suggest reaching out to your community groups, your nonprofits, your industry partners, and saying, let's work together. This is what we need to get it done. And just pursuing it and not giving up, because that's what we've done. And we're getting great support from leadership at AWS, and we're really supporting Azizi through his vision and figuring out how we can get there together. So lean in, ask for favors, network. It's like you got to get down and get dirty, but it will take a lot. I'm not going to sugarcoat that. It has taken a lot. So,
I'd flip that question around as easy. What is the cost of not providing equity care? Are we going to ignore segments of our population, particularly in an academic medical center like UHealth Miami? You're in the community. You've got to come up with answers. And what I love about what you're doing here is we actually absolutely need academic medical centers. I was a CMO at one of them. I think the challenge for academic medical centers, you can just step back and say, well, I'm not interested in the digital health and innovation in healthcare. I'm just really focusing on heads and beds, my orthopedic line, my cardiovascular line, my women's health line. You can't do that, because if you ignore that, there are disruptors out there, many of them, where I started with Hims and Hers in San Francisco. Every day, they're looking to take a slice of your pie. I guarantee you they are doing that. If you just look at LGBTQA care, real need for that in this country. There's a great startup in San Francisco called Falks. They address specifically that community. So if UHealth Miami doesn't focus in on that, they're going to lose that entire section, that entire community in terms of care. And so you can't afford not to, and we can't afford as a country just to ignore large segments of our population because it's too expensive or too hard. There's no choice.
I'm just going to kind of repeat collaboration at the end of the day, because there's a lot of things that we know, especially within my team, about how we operate with technology, but healthcare is the people in this room's arena. And that's where we lean on collaboration in that respect. And I really appreciate, reaching out for that, because that's how we start to move the needle forward in terms of what we could do in community specifically. Capital, because that was a really important part. I think people really forget how much money plays a part in actually moving these things forward. And it's from capital for pilots, so that we can actually test out some of these ideas that we put on the drawing board, but then also capital in terms of large scale execution and scaling up some of these things that we come out with in terms of, that's a good idea, it actually works. Now, how do we get it to more people? And then the last thing I'll add is engagement, right? So you collaborate, you come up with these ideas, you set aside money, but if we don't do the consistent engagement in between these kind of large scale projects that we do, you end up running into the problem that Pat just described, which is you end up being the Titanic, and you cannot move quickly enough to keep up with the market conditions and the market changes that happen in industries just like this. So, what we hope to do is continue to engage as much as possible. This was was a form of engagement, and I'm happy to be here with you guys, and hope that we can continue to push out not only messages of how much the U cares about what's happening in the ecosystem in this community, but specifically how much you guys want to do more and really elevate what universities can do in this respect. So.
Thank you. And we really look forward to leaning in on that, Eric. Just last question, and it could be rapid fire. As I think I said earlier, that I believe that there are, pointers and dreamers and thinkers and doers. So I'm going to have you do a little bit of dreaming with us. where do you see the future of health technology and more so health TechQuity?
To me, it gets back to access and cost and how we use technology to increase access and reduce the cost of care. And if technology will help solve that, we've gone a long way in improving what's going on in American healthcare.
Oh my God. I know I'm dreaming about it. I'd really love to see technology take its shape while not losing the human element of all of the kind of ecosystems.
Called Dr. Lullaby, creating a nonprofit arm of Dr. Lullaby to allow free insomnia treatment, free CPAP access. Now, the how-to is what I want to ask you guys about. We're applying for funding. Problem is, we get 1 to 2 years of grant funding. Then what? Then we say, sorry guys, you're screwed, no more free clinic. So I wanted to see, are there any funding avenues that don't just give you a couple of years of grant, but say, hey, we want to partner and we want to do this free clinic in perpetuity?
So I think what you pointed out is the challenge of startup health, right? You can have a great idea, and you can solve a problem, and certainly sleep issues is a huge problem in this country, but you also have to have a business model. Otherwise, it's hard to grow, it's hard to scale. So what you need to think about is who is going to help fund what sounds like a great idea? And is that going to be through collaboration or partnership with an academic medical center, or are you going to get a payer involved? And that's a tough part of, starting a healthcare company is you have to figure out how you're going to make the business work.
I will chime in and say, the business itself, sort of the LLC version of the business, we've been live, we're cash flow positive, we're partnered with 5 payers, that's functioning. what is inspiring to me is the non-insured. So I think that was why, and it's a huge problem here in Miami, bigger than other states, as you mentioned. And so I kind of wonder, like, okay, so we have business model A working, but like you said, it is another startup. The nonprofit's sort of its own startup, but can you fund a nonprofit for more than 1 to 2 years?
You can, but you really have to have the population has to be so big that organization, like, so down here in South Florida, there are a number of foundations that fund things. So if you don't have a business model that operates, and you have a separate one, but we're talking about the non-for-profit. If you don't have a business model for the non-for-profit that would fund itself, either a foundation has to say, this is so substantial that I would fund this for like 10 plus years, or a municipality, county, or some type of like state entity has to say, this is so important that this is now going to be something that we're able to invest in for X period of time because it helps our citizens so much, right? From municipality standard, what they're going to ask and they're going to say is, is that an area that we will want to step into? Because municipalities generally don't help with sleep issues. I have a CPAP machine at home, right? Because I have sleep apnea. And that's something that I was like, oh, I would love that. But guess what? I'm like, maybe I don't know what percentage of people who have that, right? Probably large enough, but probably not large enough for them to say that it's a need that now government's going to overstep a traditional bound that they would have in order to fund something of that nature. So that's kind of the question you want to ask is, am I lining up with something that a foundation has a clear interest in because they've said that they want to do something in healthcare, specifically with sleep, that they know is an issue that could potentially affect mental health issues, because that's something that is a huge thing for a lot of different types of organizations that are funding things philanthropically? Or is this something that clearly aligns with something that affects such a large swath of citizens that solving it actually is an economic benefit to doing so?
Any other question? Yeah, sure.
Good afternoon. Thank you so much for being here. My question is, you discussed about the digital divide. I'm curious if your organizations have any initiatives or programs for older adults, like increasing accessibility and things like that. Thank you.
My organization? That's a really good question. You know how many times in the past, and we didn't even talk about this in the roundtable, but the issue of healthcare specifically for the elderly has come up so many times, and maybe this is because I had a lot of conversations with AARP over the last year, because Miami is such a particular population in which that is a huge concern for how we're going to actually help. And they've been dubbing it silver tech. I don't know if anybody has heard that before. I don't know if that's a real thing, but I've heard it so many times that I'm like, I don't know if I like that term. I don't like terms. You got to pick them well. They hit people's ears wrong, and it just doesn't sit. So, but to that point, more seriously, our organizations truly focus, not enough, nowhere near enough to the degree in which this population is going to be affected by within the next 10 to 20 years. So I guess the question would ultimately be is, again, and then I was just Lisa, I think it was Lisa, is the same thing. What portion of the population are you specifically trying to help? And you said elderly, but specifically within that, is it the way that they live or the way that they receive care? Is it access issue? If they do have access, are they able to consistently get it? Clearly defining that helps align with a particular organization that either would philanthropically do something, or and I always vouch for this, even though I am in government, it's creating business models that you can sustain something like that through a small portion of the work that you do, right? So the bigger your organization becomes, or the bigger your company becomes, you can start to allocate certain amounts of revenue or backwards into the company to be able to carve out areas for something like this that would happen in different localities throughout the nation if there's something you really wanted to do, or you can subsidize it a bit. Because if you have to get complete subsidy from an outside entity, now it becomes a lot harder to think about how this would work perpetually as you go. But if you have a company and this company is doing rather well for itself, a portion of that you could say, could you match me in some form or fashion? And that's how we think of things. It's like, I constantly want to match things. If the city is going to do something in municipality, they want to know that public dollars are being over leveraged by private dollars in some form or fashion. So if I put up 20,000, I want you to put up 100. That has to be the calculation. Because if I'm using tax revenue for this one thing in this particular way, it has to help everybody. If I overcommit to something, so that's the consideration that has to come into play a little bit.
Yeah. Let's say, what innovations in health tech have you guys seen that successfully tackled?
Yeah, could you repeat the question?
What innovations have you guys seen in health tech? Oh, there you go. What innovations have you seen in health tech that have successfully tackled health equity so far?
I think telehealth has been a really innovative engine for care, and different ways to deliver that. But I've seen lots of small areas of innovation in telehealth in terms of opening access to care, even what we do on, the asynchronous versus synchronous care. You don't need to have a video visit. You can do it through, chat-based store and forward technology. That has opened up access tremendously for our customers. And there are more and more companies that are looking at asynchronous versus synchronous care. I was speaking at a conference yesterday sponsored by Atomic, which is actually incubated us at Hims and Hers, and they moved their whole office, just to let you know, from San Francisco to Miami. They've doubled down on Miami and what's happening here. And one of the speakers said there are three major disruptors and innovations in really technology, but also applies to healthcare. It's mobile devices, internet, and chatbot. And the one I'd keep my eye on is chatbot. I think there's tremendous opportunity and tremendous dangers in that. But if you can imagine doing counseling, CBT, cognitive behavior therapy, through a chatbot, absolutely able to do that if you can improve the quality. So I see that as one area that keep your eye on, because I think it is going to open up access and be really innovative.
I'll just take liberty to brag about the work that we're doing in the department, as well as the Media and Innovation Lab. So as I said earlier, that we've created a remote health monitoring solution whereby we've teamed up with companies like T-Mobile, where we recognize that the digital divide is a real thing. People don't have smartphones, that don't have MiFi. And so we tell people, it's on us. You don't have to worry about that. And so what we're doing is that we're testing a model and showing and demonstrating that instead of actually making healthcare be kind of reactive, that we can be more kind of on the front foot, whereby we envision a world where someone gets the mailbox, the remote health monitoring solution, and that can be able to provide data over a series of times so that the physician or the provider can really know exactly what's going on with that patient. And so here is it now that you're no longer having a healthcare system that is reactionary, but one that is on the front foot, focus more on prevention as opposed to treatment and management. And I think that's an area that is ripe for exploration. I think this is where we need partnerships whereby we can remove the digital divide, but it really takes a very strong academic health center as well as nonprofits and everyone in the community and government to facilitate those types of networks, because we do have the pieces of an ecosystem, we just haven't gelled it well together in a unified and cohesive way. All right.
Can I ask one last question?
Oh, sure. Yes.
Thank you. Thank you so
see
much
you.
for this fascinating roundtable session. I'm faculty here at the University of Miami. I like the dream where you said where the technology is no longer technology. So it's like a normal language. So as faculty in a university, shouldn't we be teaching our PhD students and medical students the language early on? How much do we teach them? I think we need to work together to change the curriculum, and so technologies like ABC, right?
So I come from the law school here, and everything that I learned about technology was outside of the law school, right? And that's not to say anything bad about the law school, because it's amazing courses that they have. And so there's some really, really powerful things that gave me an access point later after I learned a lot to be able to start doing more things that I'm able to do now in the field. But the biggest thing that universities kind of need to balance out is, how much ownership do you take over teaching traditional pedagogy, which you all have locked down and you don't have to change whatsoever, and changing or adding to that things that are happening in real time, right? So you might say to yourself, oh, we should add things about AI, but AI came more prevalent within the last year. So is that something you should pivot to right away? Because tomorrow we might be talking about something completely different. Maybe quantum mechanics catches up and makes AI obsolete in some form or fashion because of the security issues. I'm not 100% certain, but it is something that you want to keep a pulse on to help people, guide people through these processes that are changing your industry so dramatically. And, I think Pat even pointed out things that might affect healthcare more specifically, like chatbots. Like that's a real thing. So maybe that is not necessarily thing that you introduce as a particular concept, but you say there's going to be layers of modernity that we add on top of the traditional things that we teach to help people stay flexible as they're learning their more traditional concepts and topics. Exactly.
Programs that support exactly what you're talking about too. So, it's there, it's a little spotty, but working within to update curricula, I think it's critical. I agree with you. Yeah.
No, I agree. So, I think one of the things that I had shared earlier that, our bold vision in our department is that we have an education vertical, and we already have created 2 courses, one on innovation, one on health IT. It's critical. There'll be micro courses, and we envision to create more, working with medical education, because we believe that the brand or the type of physician, provider, or scientist that we will be able to produce and boast are what we call clinician innovators and scientist innovators, whereby you don't have to be entrepreneurial in nature to take these courses, but we believe that is going to be their superpower when they go out. So if you're going to provide clinical practice in Kansas, and no disrespect to anyone who's from Kansas, and you want to create a clinic, that innovation is central to that. How are you going to reach folks? And so we are trying to lead that effort along with others. I see some of my fantastic colleagues here, so that we can, and this is where it's important, that when we do well as a department, we will be able to move forward this momentum. But like the saying says, that high tide rises all boats. And that's what we want to be here in this ecosystem, here within the University of Miami, infusing it in education, but also our partners from Florida Memorial, Miami-Dade College, and other institutions. This is how we're all partnering together. It needs to be multi-pronged, not just focused on providers, individuals on the front line, but all the way from high school. And this is what we're trying to do as well, but we have to do it together. All right, so with that, I'd love to thank our fantastic and esteemed panelists, Eric and Pat and Mariko. Can we give them a round of applause again, please? So just wanted to share with you. So again, welcome to our first, community meeting. We'll be having more of these. There are many opportunities. I'll just kind of share with you that, huge shout out to Rachel and team, as well as Brett. We're doing this already, as I said, and this is why this question around education is critical. We're hosting, a micro course on case-based learning, looking at digital therapeutic solutions in healthcare, and particularly focusing on how digital innovation is changing the way we provide healthcare. It's going to be May 16th from 5 to 7. We have a course. It's digital. It can be done both synchronously, asynchronously. Scan the QR code, register. We'd love to have you. We're partnering with Click Therapeutics to discuss this. As I think I'd shared with you, in our clinical vertical, digital therapeutics is a key area that we're going to be doubling down on. My dream is to have the University of Miami be one of the preeminent digital therapeutic health systems. We're building the road for that. I think we'll get there. And we're getting, supports from the community saying, we want to learn more about digital therapeutics because one, it's accessible. We have several studies. We have a study for maternal mental health where we provide Black and brown moms with VR solutions to deal with that. And we ship it to them, no cost of theirs. Study for the elderly as well, whereby we're looking at how sleep and exercise impacts, cognitive aging, but we're using, solutions, particularly looking at cognition, where we can look at voice and eye pupillometry to do a better job capturing cognition. And the solution that we're able to help build, and this is where our department has been leading, we've found a digital biomarker for cognitive resilience that we can predict Alzheimer's disease 8 to 10 years before onset, and we can measure cognitive impairment before onset and when people will transition. What does that mean? What does that translate to? It means early detection, early care, early treatment, and providing the wraparound supports for families and individuals who may be suffering from cognitive aging. These are some of the things that we're focusing on, and digital therapeutics is the way to move there. So I just wanted to share that. Another thing that we have going on and coming soon in the fall, we're going to be having, monthly, webinars, but we're going to have an in-person session each quarter. I love the fact, isn't it so fantastic having people come together, rubbing shoulders, meeting people. If we are serious about building this community, we have to invest in time, invest in our presence. And so I'm happy to announce coming fall, we have Dr. John White, the Chief Medical Officer of WebMD, who is going to be speaking here about information as a determinant of health. And I don't want to let out too much, but we're working on a major initiative with some other big tech companies as well, focused on how is it that we can, address the issue of digital literacy and ensuring that information should not separate or prevent someone from getting good, adequate care. So we're very bullish about that, and we're going to be doing this. And so I would also like to thank the Mill Squad and the TSCS Squad. I think you'll see them in the gray t-shirts. I want to thank them so much for just their undying support. They're fantastic leaders. And one of the things, Pat, you might appreciate this, our school, College of the Holy Cross, boasts some great leaders. And one of them is Clarence Thomas. I won't get into the politics of that. But one of the things that he said that I really took to heart when he came to give a talk, he's like, ensure that you hire people that are smarter and better than you. And so the folks in those gray shirts are better and smarter than me. I just show up. They have been really fantastic, and I thank them. And last but not least, and she just left, and I wanted to call her up, Kayla. Do we know where she is? Do you mind getting her breath, please? She knew about it, yes. She knew about, well, we have a good symbiotic relationship. So I just wanted to thank Kayla because Kayla really is the chief architect behind this Health TechQuity. It's the inaugural launch of it. We'll have it this time again next year. One of the things that I will promise to the internal community as well as external community is that I will have what we call a state of the department address. This department doesn't belong to me, it belongs to you all. You have to help keep me accountable. So we're going to use the Health TechQuity Roundtable to share our successes, our failures, our challenges, and how we can work together. So you can keep me honest, with that. And we look forward to having you to our next session. I know Kayla's probably out there getting lunch ready. So lunch is outside. We're trying to find a place for everyone to eat, but it's not as open as possible. So there's a courtyard outside as well. So with that, I'd like to thank our panelists again, and thanks to Onyx. So Kayla is doing what Kayla does very well, meaning conquer the world. But when you see her, please thank her. She is really the force behind everything. And so I am so delighted to have you. Again, this is our first one, but it's the first of many. And it can only be possible without you. So we have a few raffles. Sorry, thank you so much. And welcome Ingrid, our center manager as well. Yeah, we do have raffles. We like to give away stuff. So we actually have 3 Fitbits that we are going to be raffling off today. Because, you know, this is a health TechQuity roundtable, right? We want to get people to be better users and consumers. And I tell you, this is not rigged. We were trying to get Price Waterhouse, but we couldn't afford them to ensure that this was a transparent process. So the first raffle winner, oh, can I get a drum roll? Like, the first winner is Ghislaine Archer from Pediatrics. Did I say that correctly? Oh, welcome, congratulations. Welcome. You're welcome. All right, drum roll again for the second. Owen Williams. This is not rigged. Come on down, Owen. So Owen and I share a common culture. He is my Jamaican brethren. And so thank you so much.
Thank you.
All right. And last but not least, are you guys nervous? Sorry, I know it's just Fitbits, but they're great. I think I may have to read this. The first name is Carlos, but I cannot identify the last name. So my apologies. That's more on me. I am in Bascom Palmer for ophthalmologists. I probably need to be seen. Then yeah, the ticket number is 908-063. Hey. And for those of you who didn't win, there will be many opportunities, but you have to come to our next event, right? So we'll reach out to you all. Thank you all so much. Congrats. We'll see you all in the fall, but we'll see you downstairs. First of all, oh, yeah, sorry. Yes, sorry. No, I was communicating with Kayla. So now that Kayla is here, I'm going to do this. So I think I've said this to you. Come on, Kayla. You don't know I'm going to do this. Please, a round of applause for Kayla. I think I said this when we came here and people applied for the job. I wasn't very satisfied. And when Kayla applied and I reached out to her and she didn't respond, I was telling my wife, like, she doesn't like me. Like, I think like we need to get her. So I stalked her literally on social media and I reached out to her. I did. Because she just, her resume, like she is just the real deal. And she's like, I sent you tons of emails and you never responded. And it went to spam. And so persistence is key. But the most important thing, I just want to thank you, Kayla, for putting this thing together. I think what you've dreamt about in making sure that equity is critical, that it is the flag bearer of who we are as a group. She keeps me grounded. She keeps us all grounded. She keeps us all focused. And so we would just like to thank you very much for your incredible leadership. And she has finals as well. So she was literally this morning she called me at 7 a.m. at Target saying, do we need anything else? And I'm like, I don't think so. But that's the level of commitment, right? That's the level of commitment. And the reason why I'm highlighting Kayla is because with her and through her work, that's the embodiment. That's who we're gonna need to make this a reality, right? That even though we have our titles, when you come in our group, that there are no titles. Titles just provide platforms. You just have a place at the table. So we're inviting you all to sit at the proverbial table with us. We want to hear from you, But Kayla, thank you so much for everything.
Lunchtime.
We'd also like to thank our panelists. We have a little bit of swag, departmental swag. Oh, they want the mill shirt. You don't have the mill shirt? We will get you a mill shirt. At some point, we'll give everyone a mill shirt. But thanks again to Eric, Pat, and Mariko. Really appreciate it. Orange and green, I hope you love those colors. It doesn't really bespeak innovation, but we'll change it in many ways. So again, thank you all so much. Looking forward to meeting you at lunch.
You all can feel free to make your way out the doors and grab lunch on your way out, but please feel free to stay and, talk to our panelists, talk to each other, and, continue this conversation. Thank you so much. I'm your girl. Thank you.